Вот этими стрелками, да? Good afternoon, and let us start the lecture on the management of patients with parathyroid glands diseases and disorders of vitamin D in outpatient department. My name is Galina Nikolaevna Panevskaya. I'm a docent of Department of Internal Medicine number 2. Let us start. First of all, I'd like to remind you about the tasks of outpatient department physician or family doctor, etc. First of all, you should understand and should agree with me that the most important task of any doctor in outpatient department and inpatient department is to examine the patient, to interrogate the patient, to do clinical examination, and to administer the plan of investigations, to assess the results of such lab tests and instrumental methods data, and to make diagnosis. Initially, it can be a preliminary diagnosis, but each preliminary diagnosis should be confirmed, and of course, each patient needs the correct diagnosis. This task is also actual for a doctor in outpatient department or in polyclinic. So consultations, clinical examination of patients, according all rules of medicine, according all rules of propedeutics. And I'd like to pay attention that laboratory and instrumental investigations, they are very significant if you want to confirm diagnosis. And of course, the task of a doctor is to do the correct, adequate assessment of indications for hospitalization, because many patients need not any hospitalization. You can manage them in outpatient department, but there are also many patients, a lot of patients, those require hospitalization, and some of them require hospitalization on emergency because they experience life-threatening condition, life-threatening complications, and many patients, they need hospitalization as a planned hospitalization, so they can wait some days, sometimes some weeks, and it can be acceptable for such patients. But this task of a doctor is very important. A doctor in outpatient department should differentiate such patients. Those patients who need hospitalization on emergency and who can wait for some days or maybe more than some days, some weeks, sometimes. And of course, the doctor in outpatient department has to administer treatment. Treatment includes recommendations of a diet. Treatment includes also recommendations about the regimen of the patient, and you should also administer the proper medications. Medications, those are the most effective in treatment of this concrete disease. Nowadays, they pay attention that it's not enough only to examine. It's not the patient. It's not enough to interrogate and to do physical examination, laboratory investigations and instrumental investigations, etc. And it's very important for many patients, including the patients suffering from endocrine disease, to teach these patients, to explain the patients, etiology and pathogenesis of disease, and we have to teach the patient how to behave to avoid, if they want to avoid complications of the disease, because everybody wants to stop the progression of disease and its complications. So education of a patient, it's one of the very important part of treatment. And we have also teach not only our patients, but also in many cases their relatives, their close relatives and medical workers, our colleagues of different specialties, different occupations, and nurses, because nurses are also of great importance in outpatient department and inpatient department, etc. And of course, it's very important to remember that it should be dispensary observation. Only one consultation for a patient, it's not enough in the most cases, because we want to invite the patients for the next consultation to assess the results of your treatment, the results of your investigations, etc., etc. No, I think that everything was understandable, and let us return to our topic. Now you can see on this picture anatomy structure of thyroid gland. You can see, I think that you know where is it located, near trachea you can see, and here on this picture you can see a picture, a structure of the parathyroid glands, and you can see that they're located near thyroid gland, or even within the tissue of thyroid gland. I'm sure that you studied anatomy and you passed the exam on anatomy successfully. So I want only to remind you that parathyroid gland is endocrine gland, and it's usually associated with thyroid gland. And there are normally 4 parathyroid glands, but sometimes their number can vary from 3 to 6 ones. They are small epithelial bodies with a weight to 0.5 gram. The location is posterior to the thyroid and within its tissue, and in 25% of cases it's typical. So it can be located behind the esophagus, trachea, or sternum. Parenchyma consists of parathyrocytes. Those produce parathyroid hormone, and abbreviation PTH stands for parathyroid hormone. And highly vascular, these glands these glands have highly vascular and with branches of thyroid arteries, superior and inferior. And innervations is rather common innervations with sympathetic and parasympathetic nerves. 2 to 2.6 millimole per liter. Hydro absorption. Alkaline food, usage of glucocorticoids, decrease serum calcium. What's about regulation of calcium and phosphorus metabolism? Calcitriol is formed in kidneys. This information should be also clear for you because you studied metabolism in blood. It increases excretion of calcium and phosphorus with urine and fibrous cystic osteodystrophy. And this disease is resulted in hyperfunction of parathyroid glands due to tumor of parathyroid gland or their hyperplasia. And the hyperfunction of parathyroid glands or hyperplasia, hyperfunction because of presence of tumor, is hyperparathyroidism. So Recklinghausen's disease is the example of condition hyperparathyroidism, is manifested by hyperparathyroidism. No, I think that it was clear. And incidence of primary hyperparathyroidism is morbidity is from 0.1 to 2% of the population, and it occurs mostly in elderly females and very rarely occurs in children. And what about etiology of primary hyperparathyroidism, Recklinghausen's disease? It develops due to a single or multiple parathyroid adenoma in 80–90%, or in from 0.1 to 2% of all cases. It occurs due to hyperplasia of all four parathyroid glands. And in 1 to 5%, the etiology of hyperparathyroidism is associated with cancer, carcinoma of parathyroid glands. And what about endocrine neoplasia syndrome 2, or MEN2 syndrome? And another variant of familial without multiple endocrine neoplasia can be detected only in children. Etiology of adenoma, carcinoma, and hyperplasia of parathyroid glands is not completely clear even nowadays, but risk factors are unknown. There are different infectious diseases, autoimmune diseases, radiation of head and neck, usage of some medications. In pathogenesis of hyperparathyroidism, we should remember, we should understand, and it's very understandable, very clear, that it should be chronic hypersecretion of parat hormone. And the result of such hypersecretion of parat hormone is named as hyperparathyroidism. And it leads to decrease of renal excretion of calcium, to increase of phosphate clearance, to increase of hydroxycholic calciferol. It's an active form of vitamin D synthesis that stimulates intestinal absorption of calcium and calcium mobilization from bones. And hypercalcemia is the main pathobiochemical significant factor in diagnosis and in pathogenesis of hyperparathyroidism. And on this picture you can see different ways of metabolism of calcium and influence of parat hormone and etc. You can see the different organs, they participate in metabolism of calcium, bones and intestines and kidney and liver is also participates, of course. And what about any other variants of hyperparathyroidism? Hyperparathyroidism can be also secondary. You should remember that primary hyperparathyroidism is a disease when parathyroid glands are affected. But you can meet a patient with secondary hyperparathyroidism. Is a result of hypocalcemia due to kidneys or liver diseases or deficiency of vitamin D. And you can also meet tertiary hyperparathyroidism. It occurs on a background of existing secondary hyperparathyroidism. And clinical symptoms and signs of hyperparathyroidism commonly develop slowly. It can be manifested in some cases only by asymptomatic hypercalcemia. But hypercalcemia is present. Hypercalcemia is commonly present in fissura is narrowed. And involvement of kidneys is also present. It's manifested by hypostenuria. And involvement of gastrointestinal system is manifested by anorexia, nausea, vomiting, constipation, weight loss, stomach aches, and chronic pancreatitis occurs due pancreatic calcification. Peptic gastroduodenal ulcer, they are also characteristic for hyperparathyroidism. Apathy, drowsiness, or depression, psychosis, and coma or diffuse changes on electroencephalogram. There, bent keratopathy, it's also ischemia because of hyperparathyroidism. And how to make diagnosis correctly, diagnostics of this disease. First of all, we should look for the most typical signs and how to confirm this diagnosis. First of all, we have to check the concentration of calcium, total calcium, and ionized or free calcium in, and what can be found in complete blood count. Anemia, eosinophilia, neutrophilia, but you should understand that these changes, they are not specific only for hyperparathyroidism. They're rather non-specific because they can be detected in the patients with other diseases. What can be detected in urinalysis? Once more, either hypostenuria when relative density of urine is decreased. And you should remember about Zimnitsky test. We use Zimnitsky test when we want to detect concentrative function of kidney. And what else can be also present? Albuminuria. Albuminuria criteria you should also remember. We should collect the urine per 24 hours. If concentration of gram, it's albuminuria. If it's more than 30 but less than 300 milligram, it's named as microalbuminuria. Biopsy to confirm diagnosis. No, of course, this method should become invasive because biopsy should be done under control of ultrasonography. What else is also used in diagnostic? X-ray or tomography of retrosternal space with contrast agents, scanning of parathyroid glands, selective arteriography with contrast agents, and magnetic resonance imaging, MRI. And X-ray gram of skeleton. What can be detected? Signs of osteoporosis and multiple cysts. Decrease of vertebral corpora height. They're named as fish-like deformation, as fish-like deformations. And on this X-ray gram of skeleton, you can see typical fish-like deformation. Radiographic features of spinal osteoporosis include wedging of the vertebra anteriorly with vertebral collapse, vertebral and end plate irregularity, and general demineralization. So, in other words, there are signs of osteopenia and osteoporosis. Now, on this photo, you can see the room and the patient and a doctor. You should understand that this patient needs a radiographic. What else is also can be beneficial for diagnosis? X-ray gram of skull. You should understand why, because if there are miliary granularity with reification, we can suspect another disease, so maybe myeloma disease, maybe metastasis, and thinning of cortical layer of joint. They use functional thyroidism. Hyperthyroidism, for example, hypervitaminosis D or hypervitaminosis A, immobilization can can lead to the changes thyroidism. We have to interrogate the patient properly sarcoidosis, Addisonian crisis, Paget's disease. Paget's disease is characterized by arthrosis, bone pain, cyst on the X-ray films. Differentiate osteoporosis in the patients with hyperparathyroidism, primary hyperparathyroidism, Recklinghausen's disease, with osteoporosis because of postmenopausal metabolic changes of calcium, hip bones, skull, ribs, and it's manifested by bone pain, fractures in typical places, and presence of cysts, bone deformation, biochemical abnormalities is also significant. Now on this picture, you can see typical vertebral changes in osteoporosis. There is deterioration of vertebral support, and you can see that the age of this woman, she's elderly. Maybe this osteoporosis occurs in postmenopausal period of her life, and genetic signs occurs even in the first months of life. Calcium and phosphorus and hyperparathyroidism in children occurs extremely rarely. Usually it's the task of the doctor's pediatrician and endocrinologists, those manage children. And another disease, the next disease, Ewing's sarcoma. Investigations are decreased. Pseudohyperparathyroidism is also characterized by tissue tolerance to parat hormone. It depends on decrease in activity of the specific. It's named as guanylatory protein or GN protein. This protein provides interaction between a receptor and a membrane of adenylate cyclase, and it participates in realization of functions of this enzyme. Such abnormality leads to clinical pattern that look and spasm of smooth muscles or facial muscles cause the sardonic form of a mouth. It's also named as a fish mouth. There comes a spasm and it's named as trismus. And spasm of smooth muscles of internal organs can stimulate an acute abdomen, a renal colic, and a heart attack. Contrast minutes after pulling a shoulder by a plate or cuff off a device for blood pressure measurement. Schlesinger's symptom is spasms in extensor muscles of a hip and foot at fast passive bending, a leg and in a hip joint at the straightened knee joint. Again, Schlesinger's symptom, you should remember, Trousseau's sign, and khvostek, in Russian pronunciation, khvostek sign, that you could study these symptoms and signs at the Department of Neurology. Diseases of the nervous system. What else is also can be detected? Any other symptoms and signs? Trophic abnormalities in ectodermal structures, defects of dental animal caries can be present and progress. It can be progressing earlier, turning gray hair, atrophy, and fragility of nails, dryness of the skin, eczema, dermatosis, candidiasis. They are very typical for hypoparathyroidism, cataract, and papillary swelling. What about cardiovascular system? You can detect hypertension in the patients, tachycardia, arrhythmia, spastic cardialgia, elongation of QT and ST intervals without change of wave T and resistance to cardiac glycoside. And what's about gastrointestinal system? Spastic pains in the stomach, you should remember why, because of a spasm of smooth muscles and pylospasm with vomiting. No, first of all, we have to interrogate the patient properly, very carefully, in all details, necessary details. It's very important to ask the patient about surgery, surgical intervention on thyroid gland in anamnesis. No, because of different diseases of thyroid, maybe goiter, maybe diffuse toxic goiter, maybe multiple nodular goiter, maybe thyroid cancer, no, etc. Hypocalcemia can confirm diagnosis, and hypocalcemia and at the same time hyperphosphatemia. Decrease of parathyroid hormone in blood, hypocalciuria and hypophosphaturia, and syndrome. There are epilepsy, hypoglycemia. You should remember that hypoglycemia is also manifested by convulsions. Hypoglycemia is severe. Tetanus, poisoning with strychnine, hydrophobia, long-term vomiting, alkalosis, syndrome of malabsorption, hysteria, lack of magnesium, etc. And what else should be differentiated with? What another diseases? All diseases and conditions accompanied by a cataract. Hypocalcemia due to insufficient absorption of bright mercury. What preparations are the most popular in clinical practice? Well, I'd like to tell you about calcium gluconate, 90 milligram in one tablet. It should be taken 3 times a day or 4 times a day. Calcium lactate, if the dosage is 50 milligram in one tablet, should be also taken 3 times a day or even 4 times a day. No, there are different variants. And what else is also of great importance? To do control of calcemia level each 3-6 months, from 3 to 6 months. But it's obligatory. It's very significant. And what should be also administered? Metabolizer of vitamin D, D3. And the dosage is 50,000, 100,000 units. Sometimes the patient needs higher dosage. For prophylaxis, the dosage for adult individual should not be more than 500,000 and 1 million units a day, and initial dosage should be less 250,000 up to 400,000 units daily. And the names of medications. Calcitriol is used in treatment of hypoparathyroidism. It's named as, trade name is Rocaltrol. It's 1.25 double hydroxy vitamin D3. Alpha calcidol or alpha D3 is a synthetic analog of cholecalciferol. And nowadays they use also tachysteine. It's a synthetic analog of dihydrotachysterol. What else is also discussed in scientific medical literature? You should also know about it. Parad hormone preparations are used rarely, and surgical methods such as replanting of conserved bonelets for formation of depot of calcium, they can be used. They can be used. And such surgery should be repeated because it's impossible to keep this depot of calcium for a long period of time. And what else is also used nowadays? Autotransplantation of parathyroid gland. I'd like to pay attention that you should also know about complications, urgent complication of hypoparathyroidism. And urgent complication of hypoparathyroidism is named as acute attack of, it's a crisis, and it's manifested by acute attack of tetany, and it should be supervised by intravenous infusion of 20 to 60 milliliter of 10% of calcium gluconate or calcium chloride solutions. And it's very important to know and to do because this complication of hypoparathyroidism is urgent and it's life-threatening complication. Of course, it's better to avoid, to prevent it, to manage the patient properly, but if you have met with such acute attack of tetany, you should know how to improve situation, how to save your patient. Thank you for your attention. My lecture is over. No, I think that the most of our patients, the most of our students were present at my lecture, and you listened to my lecture. Thank you for your attention and the best wishes. Goodbye. Я уже закончила. Там, я не знаю уже какой там результат, может вы мне его пришлете
М,
в почте или это сложно.